So let's start with the first question. Does this patient have renal disease? Maybe, does anybody want to have a shot about? Yes or no? Yeah, okay. So just one person out of everybody, okay. Is serum creatinine a good measure of renal function? Again, show of hands is fine. We don't have any other. Nodding, you're nodding no, okay. Should we use GFR or clearance markers? Yeah, okay. Are there any other markers? Anybody can shout out anything if you know? Yeah, good point. So that comes back to the first question, that does he have renal disease? Okay, excellent. So what is the role of isotope scans? That's difficult to answer by hands. And are formulae that are validated, yes or no? Okay, so we come to the next, sorry, that's just me. Okay, does this patient have renal disease? Quite rightly, as someone says, two windows to kidney disease are essentially estimation of creatinine and presence of proteinuria. Now, serum creatinine, however, itself is not enough, is the bottom line with this, and GFR must be calculated, but why? So everybody knows roughly that it should be done, but why exactly should it be done? So normal serum creatinine interval does not necessarily reflect the GFR. That's very important. This is due to the fact that there is a non-linear relationship between creatinine and GFR. And it goes somewhere like this, where initially there might be a little change, a large change in GFR, but a very little change in creatinine. But later on, that changes quite significantly. So it's non-linear, essentially, is the crux of the situation. So we need GFR, we know that. Okay. The next point was, is serum creatinine a good measure? So creatinine itself is a byproduct of two things, which is creatinine and phosphocreatinine, found primarily in the skeletal muscle. And so it depends really on muscle mass, which is simple to understand, and protein intake. Released at a relatively constant rate, but some of it is secreted by the tubules as well, which is an important point to make. So, therefore, highly variable results. Inter-lab discrepancy, as all of you will understand in your private practice, is immense. There are highs and lows based on different interfering chemicals. Two methods usually that are used are modified JAF and enzymatic method. I'm not going to talk about that. I'm just going to say one thing, that basically if there is an NABL accredited lab in India, then they have to use a universally universally accepted tracer, which is done with an IDMS method, and then they standardize their creatinine test based on that. So if it's not NABL, you have no idea what their basic creatinine is based on. So the point to make is that if the creatinine is wrong, the GFR is going to be wrong.
Can I interrupt?
Yeah, sure, Dr. Lobo.
So, some years ago, there was a study called the SEEK project, which was done by the Brigham and Women's Hospital from Boston in India. What they looked at was 20 different laboratories, serum creatinine measurements, and they compared them with the reference standard, which was Brigham and Women's Hospital, Boston, and they found a huge variability. And only one lab in India, which at that time was SRL Ranbaxy, could match the international standard. Subsequent to that and the publication of that study, as Mitali said, all NABL accredited labs now have to use the universal tracer. So if the lab is NABL accredited, then creatinines will be fairly not just reliable, but also reproducible. Because if you have two creatinines in two different laboratories, you could have one value of 1.2 and one of 1.8. It could be as variable as that.
So,
Mitali, I have
yes,
a question for you.
Yeah.
Now you are comparing the creatinine values of the Western standard.
Yeah.
Which are, those people are highly muscular.
Quite right.
And they are quite robust compared to the Indian standards. Do you think the creatinine that they have will match our standard? Do we have any Indian data on that?
So, you can answer. I said you were going to show it. Yeah. I'll come. Yeah. So, we'll come to the next bit, which probably says this point quite clearly, that the GFR really is assessed essentially from the clearance filtration markers. Now, it's the volume of plasma really that is cleared of the substance per unit time. Essentially, not very complicated, you're clearing that particular volume of that particular substance. Now, that brings us to the point of GFR, which sir also mentioned, that basically glomerular filtration is equal to the sum of the filtration rates of all the functional nephrons. Okay, so if you think of the fact that N is a number and single nephrons are SNGFR, then that is therefore related to your surface area, which is then related to your kidney size, which is then related to your body surface area and your metabolic activity. So yes, there is a definite difference between what is the Caucasian population and what is an Indian population. It also changes with your renal size. So body surface area is calculated by using various formulas for the functions of height and weight, which is very important to kind of summate from that. Now we have a huge lot of calculations, and again Dr. Lobo said as well, there are lots of apps these days that do that, but this just gives you an indication that from 1973 we've been doing this. You know, it's not new. We've been doing this, we've come down to 2010. So what do we do with all this information? We got to the 4 main ones. So Cockcroft-Gault was the main one, but again, it was only in hospitalized white men. Okay, this is very important to understand. MDRD, which you have all heard about, was in non-diabetics. Okay, so not really, and only in CKD 3 and 4, which is also a very important point. The CKD EPI study, which was in 2009, was then a more inclusive study which went to younger ages, diabetics, transplants, and definitely performed better for more than 60 GFR. Now, because of inadequacies, though, because of all of this, in 2010, the National Kidney Foundation said, okay, you know what? Every creatinine will be followed by an estimation of GFR. So every time you do a creatinine, you have to estimate GFR, and that will help us allocate stages to CKD. And I think that was quite a that was the turn in the century, really, to say that. Now, the gold standard is inulin. Now, you've heard of this inulin. Basically, it's freely filtered, not absorbed, but it's really quite impractical. I mean, you can't be using inulin on every patient. Because of these reasons, you can't really do it, okay? So then what else? So there are endogenous markers that are developed by the kidney, by the body itself, or there are exogenous markers. So endogenous markers are creatinine itself, and yes, we do creatinine clearance, which is you have to collect the urine for 24 hours, and it does. However, that itself can be quite inaccurate, and as you know already, creatinine itself is not an ideal marker, okay? So then what? Then exogenous you can do through radioisotopes. So radioisotopes are DTPA, EDTA, iothiolate. They've all been used, but really it's quite costly, and you are exposing the patient to radiation at every time. So are there any markers besides creatinine to assess CKD? And this you must have seen in quite a few labs saying that we now do cystatin C, or cystatin C is the new thing. And it's just a non-glycosylated protein which is produced by all nucleated cells. Again, the key point being that it's freely filtered, not absorbed, and no tubular secretion, again, like creatinine. So, unlike creatinine, sorry. So predicts better outcomes apparently in older populations, but thing to remember is it's also affected by other things like sex, ethnicity, steroid use, thyroid, etc. So what should you be doing really? First of all, does anybody send it? Has anybody sent it? No. Okay. And really, the answer would be no. That's fine, because the current guidelines are not based on it. And it is still being validated in these various populations, so we don't know the importance of it. It might change over time, but certainly now it doesn't make sense. Now, what is the role of the isotope renal scans? Now, this Gates kind of method is a computational thing which is used on a DTPA scan. Okay, so the DTPA scan is an isotope that is injected. It then produces an image on the gamma camera, and based on that, this Gates will compute a GFR for you, okay? Now, the main point, however, is this. What is the formula that we can use as Indians for GFR estimation? And really, that's the important point. So, Atul Moy and Shefali Gokhlik did a study in 2017 which looked at 105 patients, and they looked at the Gates method. Then they looked at the actual plasma DTPA, so that's a plasma way of estimation of GFR, and then they looked at these 3 formulae, so Cockcroft-Gault, MDRD, and CKD API. Firstly, to say that more than DTPA, the creatinine, the actual equations did better, number 1. And number 2, CKD API was the most accurate. So the bottom line to this is that in Indian patients, we have certainly started using CKD API as your guideline, more than your MDRD. So now I'll just pass on the mic to Dr. Vipul, who will come and tell you about these bits.
Yeah. Before Vipul,
Oh, sorry. Yeah.
So my question is that
Yeah.
these patients you have taken, the OPD-based patients or indoor patients?
So for which one, sorry?
Was done.
Yeah.
Are they hospitalized patients?
No, they were not hospitalized patients. They were.
We have tried to use CKD API in a hospitalized lean older
Yeah.
individuals and turns out to be wrong. And when you use Cockcroft Galt on those patients,
Yeah. So there is a slight difference to this. If you're talking about drug dosing versus EGFR, okay,
no,
first
when
of all,
you say it's wrong, what did you measure it against? If you say CKD API is wrong and Cockcroft Galt
that is the only creatinine clearance we can measure.
So first of all, that's the point. So first of all, GFR is only valid if it is a stable situation, okay, in a stable situation where you are measuring, serial GFRs, serial creatinines, and you're measuring a stable situation where you are. A hospitalized patient is not a stable. You cannot use GFR for hospitalized patients. In that, for drug dosing, from time immemorial, they have used Cockcroft Galt, and they still use Cockcroft Galt. However, and in that also we have changed our thinking as time goes on, because we have come to the fact that volume, your main dose is dependent on volume, and your maintenance dose is dependent on kind of how you do it later is dependent on your creatinine clearance. And that too, if you have a CRRT patient, for example, you use a 30 to 35 EGFR. To say that that is their clearance. Yes. 30 to 35 is their creatinine clearance. So there is a big difference between hospitalized unstable patients and OPD stable patients.
So basically, whenever you want to validate a formula, it has to be validated against a reference method. Now the method that was used by Gokhale and Atul Moe was a reference method. As Mitali explained, it's based on the fact that they would inject technetium-99, they would then measure the technetium-99 activity in the plasma and also the technetium activity in a time urine collection. So that becomes a marker of how the plasma is being cleared of the marker, and that is accurate. Now, when you do, as she said, in hospitalized patients, you have lots of other factors, including the accuracy of the collection. It's not easy for a patient to do a 24-hour collection, even in hospital sometimes, and to keep it all. She also mentioned formula and what happens. So the Picard study, which was a study which looked at several formulae against timed collections in patients in hospital who were non-oliguric, and they actually found that it was the modified Gelife formula which was the best in that. So that has been valid. So any method which we want to measure must be estimated against a gold standard or a reference method, and the gold standard today is a clearance method. Since we cannot do inulin, then technetium-99 clearance, not the DTPA renogram, is the gold standard.